Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Today I wanted to provide you a brief update as it relates to a current publication, the Annals of Internal Medicine, by the U.S. Preventive Task Force Services and their updated guidelines as it relates to colon cancer screening recommendations. Now, I've had a lot of questions in my practice as it relates to this publication. Patients have seen this in the lay press, doctors have asked about it, so I thought it would be poignant and pragmatic to spend a couple minutes with you just to give you an overview and really the highlights of this report. First, the report presents an update from 2002 when the last guidelines were published. But this report is a little bit different. They commissioned a systematic review of the literature with four focused questions. One, looking at, is colon cancer screening providing a benefit, looking at the endpoint of mortality. Two was to look at the relative sensitivities and specificities of the current tests available for colon cancer screening. Three was to look at the relative value as it relates to the benefits in community practice for colon cancer screening. And four was to look at the relative potential harms for colon cancer screening, looking at each of these modalities. The parallel part of this report was a commission decision modeling analysis looking at the relative cost value as it relates to each of these modalities. Now, let me give you the 30,000 foot view. First, the question about should you ever stop screening. This is the first report by a guidelines group that suggests that maybe you should at a certain age. The group came out very strongly saying that 50 to 75, it was a grade A recommendation to begin screening at 50 and to continue screening through age 75. For 76 to 85, the group suggested that it should be an individualized basis, that it should not be routinely recommended. It was a grade C recommendation, meaning that there was modest evidence to suggest that there may be some benefit, but not potentially as clear that the harm would be not potentially more outweighing, and that this should be individualized. And then a grade D recommendation for age 85 and greater, saying that potentially nobody over the age of 85 should be screened because the benefits were probably de minimis relative to the potential benefits. So this is very different than most of the other guidelines. The guidelines committees for the ACS, Multi-Society Task Force, and the current forthcoming guidelines of the American College of Gastroenterology has wrestled with the age to stop screening. And although we have not published this and put these in the guidelines, pragmatically what we've said is begin a strategy of when you expect the patient to outlive the potential benefits of screening. And then if the patient's viability or comorbidity is such that they are not expected to live 10 years, then pragmatically it's not justifiable to screen. But that's never been put in press as dogmatically as the U.S. Preventive Task Force Services. So I think we need to keep that in mind and potentially discuss these things a little bit more pragmatically with our patients. So the benefit as it relates to the decision of cost effectiveness was also very important, and to recognize that there were three strategies that provided equal cost effectiveness. One was colonoscopy every 10 years. That makes sense, and it's part of the recommendations from the other society guidelines. Two was fecal occult testing as it relates to the more sensitive tests, so the Hemoccult Sensa in particular, or FIT, fecal immunohistochemical test, done annually. Three may surprise you because it was flexible sigmoidoscopy coupled with the more sensitive Hemoccult test. So the strategy here was a combined test, fecal occult testing done every 3 years, superimposed on a flex sig test done every 5 years. Those are the most cost-effective strategies as it relates to the application for best dollar spent and value gained. So I think it's important to recognize the age to screen begins at age 50. The age to stop should be individualized, and certainly I don't want to hold patients to an individual age as much as the physiology of how long we expect them to live. The benefits of screening are categoric. This document continues to support that. Potentially now we may want to incorporate when to stop screening. Recognize that these guidelines are for screening. We're not talking about surveillance, where I think the same strategies hold true there. When you stop surveillance depends on how long you expect the patient to live. This guideline is likely to receive a lot of attention. It's important to understand it. I would invite you to read the 40+ pages in the annals, in particular to get some more strategies that may be more expansive from today's discussion. Hopefully I've tweaked your interest a little, and I invite you now to connect with your colleagues and discuss this by clicking that module below on your web page. I'm Dr. David Johnson. I look forward to discussing another topic with you in the near future. Thanks for listening.